Okay, welcome back, everybody. We are ready to continue with our second talk. I'd just like maybe to have a brief comment to remind to some of you who may not know that for a lot of people today, especially all Europeans in particular, today is Labor Day, and it is a Saturday afternoon, and so that also shows how much we love this meeting in a way. So it's really working well. But anyway, without further ado, I don't really have to introduce much. Our next speaker is actually the chair of the session, and as he said himself, he has been my mentor in the past. There is a lot of Rochester in this session, and so it is my honor to introduce Wojciech to talk about heart rate and QT variability in the long QT syndrome. Please, Wojciech.
Thank you very much, Fabio. It's my pleasure to be at ISKI. This is my favorite conference. I'm going to speak today about these aspects of heart rate and variability in long QT. We already know that QTc duration is an important factor determining the risk of cardiac events in long QT patients. We heard from Alan a moment ago about various attempts to look at QTc morphology, and here I'm recalling on the upper right one of the important work of Jean-Philippe Couderc, who did computerized analysis of long QT patients and trying to document exactly similar topic of symmetry and other aspects of morphology of T-wave. And on the bottom, we have relatively recent publication in Circulation Arrhythmia Electrophysiology that was done by Piotr Platonov, who will be our speaker soon, and who did analyze with us some value of abnormal T-wave morphology in LQT2 patients. And you may see on the slide that the situation is a little bit more complicated. On the left, we have males who have very few events, but also they do not benefit from different morphology of T-wave, whereas females on the right, they have much higher risk, as we know, but at the same time, abnormal T-wave morphology identifies them pretty well, so there is some sex-related difference. But we're supposed to speak not only about QT duration and morphology, but mostly about variability of QT and heart rate. So about 27 years ago, Fabio and I, we presented this particular slide from one of our halters of patients with long QT syndrome, showing this tremendous T-wave alternance in numerous leads, as you see over here, showing how dynamic these changes are. And at the same time, we were interested with T-wave alternance, which was overt, like the one which we looked a moment ago, and we identified that yes, it goes along the longer QT, and that really high likelihood of T-wave alternance happens when you have significantly prolonged QT. In the same paper, we look at the risk of cardiac events in this patient, and we identified that T-wave alternance was not independent risk factor, since prolonged QT overwhelmed value of T-wave alternance in predicting cardiac events. But we were also interested in not only in this T-wave alternance, but also in aspects of variability. These are two papers from ISKI by Jean-Philippe and by Laura Burattini. We're looking at aspects of microvolt T-wave alternance and also at variability, and it was presented in 1998 ISKI. And those both papers show increased incidence of those abnormalities in the respective population with long QT. And this is what we were talking about at the time, that yes, there is alternance, which you can see in the upper panel, where you have every other beat with T-wave going up and down, and you will have non-alternating variability at the bottom, where you see with relatively stable heart rate, how varying repolarization could be in long QT patients. So this is what was triggering our interest in QT variability. What is QT variability? Why it could happen? We understand that there is obviously some abnormalities in ion channel work, and this is example from very elegant work from about the time by Mark Hagney, who also participated in a number of our risky meetings, who did show that in left ventricular dysfunction model, you may see tremendous variation of action potentials, whereas in stable animals without heart failure and dysfunction, you see that this variation on bit-to-bit basis is really small. And this is not only work in this type of LV dysfunction model, but also if we look at disotalol in dogs with AV blocks, which is also one of the classical models, you see that this variation of action potential is really large and gives rise potentially to early after depolarization. And on the left, we have some instability leading to torsade de points in those dogs which were tested in this particular study. So there is some experimental evidence that bit-to-bit variation of repolarization is proarrhythmic and could eventually lead to sudden death. One could look at it from computerized perspective, like in this work by Jean-Philippe and colleagues, who look at QT clock over 24 hours, and you have this cloud, which is representing really how varying QT is over 24 hours, and thickness of this band may already give you some idea that it varies from hour to hour or day and night. Speaking about these instabilities, obviously, when we have such unstable QT, we are worried that it will end up with torsade, the short-long-short concept, which in this case is triggered by PVCs. As I showed you a moment ago in this dog model, early after depolarizations, there could be really triggered by variability of repolarization and subsequently ending up with such long episode of torsade, which fortunately looks like stops spontaneously. The important aspect of long QT, as you know, is that there are some triggers which may prompt patients to have events, whether it will be loud noise, whether swimming or water or excitement, or in some cases exercise. And we are aware of those triggers, and a number of papers were published by a number of groups, not only ours, but also Peter Schwartz and Silvia Priori and several others, speaking about what triggers could happen. Why I'm bringing these triggers? Because, of course, if you have trigger, you could have eventually some form of autonomic dysfunction or autonomic reaction. So if you have loud noise, you happen to have subsequently instability of heart rate or instability of repolarization and leading to arrhythmia. And the graph below is from some case report with Dr. Moss and Dauber describing our long QT 11-year-old boy was called by teacher to answer some question. He stood, and he fortunately had defibrillator. He was successfully resuscitated. So altogether, the reaction to sudden arousal stimuli can lead to those abnormalities. So this brings us a question: what about heart rate and heart rate variability? So when we speak about heart rate variability, I recall one of the papers from 1996 by Dr. Hiroshi Morita and co-workers, and he looked at some group of long QT patients versus controls. And what you can see here, that LF-HF ratio was really lower in long QT. And when they look at people among long QT who developed torsade versus didn't develop arrhythmia, you see that there is lower value. And when they analyze the details, they identify that lower LF-HF ratio in long QT patients was mostly due to high frequency component. So kind of like higher vagal tone in the people who are more likely to be long QT or more likely to develop arrhythmic events. We had pleasure to have Dr. Juha Perkiomäki for 2 years in Rochester some years ago, and he was interested in heart rate variability, and we look at some Holters we had at the time, 27 carriers and 34 non-carriers, and as you see from that work, there was no significant difference in HRV parameters, including some nonlinear, which are shown at the bottom. We look obviously also at people who were off beta blockers, which were fewer among the LQ2S carriers and sample size was small, but there was no difference over here. And we look at very small numbers at the bottom for at LQ21, 2, and 3, and we could not find a difference at that time. Juha Perkiomäki at the same time looked with us at some aspects of QT variability and T-wave variability. And what was found in this group over here of 38 carriers and 20 non-carriers, that there was no, again, difference in heart rate variability, but there was significant difference in T-wave or QT variability among people with long QT versus not. So somehow indicating that this instability of vaporization is present in this disease. Dr. Peter Schwartz, but with Dr. Alberto Porta from Milan being pretty much in charge of this particular observation, they analyze about 20 or 15 carriers and about 20 or 30 non-carriers from South Africa, where Dr. Peter Schwartz is working too, and they analyze whether some aspects of heart rate variability could be identified in arrhythmic risk of long QT1 patients. They had some large cohort of LQ21 patients coming pretty much from one proband over there. And what they found that in fact healthy autonomic control confers a high risk, whereas patients with higher sympathetic control of the QT interval and the reduced vagal control of heart rate are at lower risk. So again, a lot of variation in RR, which we consider as sign of health in post-infarction patients. This might be not that healthy in long QT patients because their instability of heart rate and subsequently repolarization may predispose them to higher risk of events. We had large NIH grant together with Dr. Richard Lane, who is psychiatrist from University of Arizona, and several co-workers to focus on daily emotion in long QT syndrome and also coronary diseases comparison, but mostly long QT syndrome, looking to what extent daily changes in daily reactions, emotions will create any changes in repolarization. The study briefly was conducted by 3-day Holter recording, during which 10 times these people were paged, and they responded to some brief questionnaire on smartphone, indicating their feelings, whether they're happy, upset, anxious, or you name it, variety of emotions. And in this cohort, as you see in the table, we had 160 long QT patients. We have some young healthy, about 50, which were age matched. We also look at older healthy and coronary patients. We'll skip this group right now for the purpose of this talk. And the main finding of this study was that in fact there was quite significant difference between young healthy and long QT in response of QTC to various emotions, especially this so-called activated positive affect emotions was the most pronounced. So kind of like somebody got really excited about something, and this caused more prolongation and more instability of QTs than we expected originally. Having this cohort, we'll look at heart rate variability parameters in this patient. And as you see, there is pretty large cohort, 160 versus 50 young healthy people, and age is about 36, 34 on average, so pretty similar. Obviously, QTC is longer in long QT patients. Heart rate is lower in patients with long QT, since obviously 60% of them were on beta blockers. And as you see over here, we have a few heart rate variability parameters, and HF, again, like was alluded by this group from Japan 20 some years ago, seems to be higher in these people. Similarly with RMSSD, at the same time SDNN didn't change, didn't differ, and when we speak about LF, there was no significant difference. So despite common beliefs that maybe sympathetic drive is different in long QT versus not, we again couldn't confirm it in small prior studies, nor in this one, and the same finding came from this Peter Schwartz paper I just mentioned. We were interested also in genotype, in subset of these people. We look at genotype, and they were pretty similar in terms of their clinical characteristic or beta blocker use. And we look at their HRV by genotype, and as you may notice, there is no really difference between two columns in terms of all those parameters I'm showing. So it looks like genotype does not really change that much HRV parameters in long QT patients. We at the same time look at T-wave and QTC among genotype, and T-wave complexity, as we know, was higher in LQT2. We came back to repolarization variability using variety of measures, whether it was standard deviation of QT or QTP or QTVN or QTVI, which was proposed years ago by Dr. Berger from Hopkins. And we see that in all cases, there is difference in LQT2, seem to show higher level of repolarization dynamics and variability than LQT1. We also look at QTRR slope and also individual QTCI correction, which show different coefficient in those two groups. So definitely there is different phenotypic presentation from QT variability and QT dynamics perspective in LQT2 patients. The question could be asked, what about people who happen to be off beta blocker versus on, and especially looking at those variability parameters, you see that in both cases there are differences between these groups. So even among people who have been off beta blockers at the time of recording, they do not, they still have significantly different higher variability in LQT2 versus LQT1. We raise the question of day versus night recording, and this day-night recording also differ similarly. So it was not that just parasympathetic dominance during night versus day will be dominating it. We look at males and females, and obviously there are fewer males here, but trends the same nature. Lastly, what we also recently done, we look at some aspect of QT variability depending on heart rate, average heart rate on given period. This was done by one of colleagues who worked with us for some time, Dr. David Auerbach, who right now moved to University of Syracuse, and he and his colleagues look at a cohort of 15 LQTS non-carriers versus 42 LQT1 carriers and 26 LQT2 carriers, not on beta blockers. And what we could see is that depending on the heart rate, minimum, mid, max, you may have more variability at minimal or mid heart rates versus max heart rates in long QT patients versus healthy. So altogether, probably interrelationship between QT variability and heart rate is of essence. In conclusion, summarizing this brief talk, I would like to state that QT variability significantly increases in long QTS patients in comparison to controls and is higher in LQT2 than LQT1 patients. The work done by Laura Burattini and by Jean-Philippe years ago shows that LQT3 patients also have increased level of QT variability in comparison to at least non-carriers. However, we don't have really until now good data to document the association of this QTV with cardiac events. So we lack kind of prospective follow-up studies after such halting is done with sufficient power to claim that this is an independent risk factor. Regarding other aspects of the talk, LQTS patients show higher level of HRV parameters indicative of parasympathetic modulation, and it seems that higher vagal tone in these patients might be associated with cardiac events. Again, data are limited, including those from Alberto Porta, but we definitely will be interested in exploring this further. Thank you for your attention.
Thank you, Wojciech. While I see if there are some Q&A popping up, maybe just a quick comment, and if you want to elaborate a little bit further. As it is always the case with the artery variability, unfortunately, I must add, there is always some discordant finding in the literature, and there is lots of literature as nicely shown today. Sometimes, especially when it is related to the spectral parameter, and as we know, LF, HF comes from the spectral, let's say, component of the artery variability, the difference may arise from methodological difference. And so, as I said, this is just maybe a comment on myself, but I would like to get your opinion as well. So I'm wondering whether some of the discordancies, this lack of finding that were found in some population with respect to others, now regardless of the fascinating hypothesis of increased vagal tone, of course, this discrepancy could actually come from some methodological pre-processing, the way you treat this data, the way you filter them, as we know, is very sensitive for artery variability. I don't know,
yes.
Because
I fully agree with you that the issue of annotation, issue of correct, obviously, analysis is of essence. We pretty much always have a question when we do it about spectral methods, and we always wanted to make sure whether there is concordance with at least RMSSD or PNN50. And in this case of the last analysis I showed, we saw and showed the full concordance of the RMSSD, which is probably a more reliable time domain method, or more robust, or more or less prone for technical or noise issues, was able to show the same pattern. There is obviously still room for some pre-processing issues, but we have used the programs which are standard and done by our group for years and decades, and I think that there are really pretty much the same type of programs you have used years ago when you were with us. So I don't think that this is a difference that this methodology will influence us much. And for example, when Juha was here, he was using some of his Finnish programs. The sample size was small. He couldn't find difference in his hand, but this could be because of smaller sample size. I don't know that. For some reason, maybe my mistake, I don't see QAs on my screen. They are not showing up. Oh, I see in chat some question from Piotr.
Yeah, so let me read the question from Piotr. Your finding regarding different effect of positive and negative emotions on repolarization in LQTS is intriguing. Any speculation regarding possible mechanisms?
We spent really almost like 2-3 years trying to analyze this data with Dr. Lane and Rice. Dr. Lane, psychiatrics, Dr. Rice, psychologist from University of Rochester, the other one from University of Arizona, and our statistician colleague from Arizona. And we try to figure out what would be the mechanism. So we've done this analysis on QT, adjusting for heart rate, adjusting for HF level, testing whether these QT changes in modulation could be modulated by level of given heart rate at the time of paging or level of HRV, which is obviously short 5-minute HF. But after all these adjustments, which we've done for that paper, we were still able to show that some of those immediate emotion, were able to change QT and change much more in LQT2 than LQT1 patients. And healthy had very minimal changes. Well, I didn't focus today on patients with coronary disease, which we also reported. They had much lower level of changes than long QT patients, more along the line of LQT1 than LQT2. So it looks like that daily emotions, both positive and negative emotions, may change repolarization to base of our analytic approach, even after adjusting for sudden changes in heart rate or heart rate variability as we could measure. So this is what I could comment on at this stage.
Okay, I think we hit the hour. So if I'm not mistaken, we have a 10-minute break. So I look forward to reconvene in 10 minutes time. Thank you.
Thank you very much.